Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Welcome to the Low Carb MD podcast. Today we have a great guest, somebody who I've talked to several times, met at conferences on metabolic health. It's Dr. Paul Polo, okay? Dr. Paul Kolodzik. I hope I got that last name right. Your last name is as hard as mine, Dr. Kolo. He's the Metabolic MD. He's been practicing in Ohio. Amazing guy that I've gotten to connect with over the years. He started out his undergraduate education at Notre Dame. He went on and did medical school at Wright State. He did his emergency medicine training at Wright State. And he's been practicing metabolic medicine for the past several years. He's written a book, The Continuous Glucose Monitor Revolution. And I highly suggest you go out and take a look at it. We'll put the link in our notes. And a little bit ahead of the time because he wrote in the title for non-diabetics. And guess what? Last week, the FDA said, actually, we agree, right? And we'll talk about that later today. But we got, can I call you Paul? Paul?
Yeah, sure.
I'll be Tro
Absolutely.
and you'll be Paul.
Yeah.
Awesome. Paul, thanks for coming on. I know Brian's had you on before on his podcast. We're happy to have you here.
Yeah. Thanks for having me back. And I think I was with you a couple of years ago, Tro. So I really appreciate you having me back.
Yeah. So tell us, if, oh geez, gosh, I didn't even remember that. That tells you something about my memory, but tell the listeners, just a lot's happened, I guess, since the last time you've been on. For some reason, I thought you went on, Life's Best Medicine, and I'm forgetting now that it was actually our podcast.
Yeah.
But tell the listener what's been going on in your own practice since then. What's been going on in your career since then, and maybe we could talk about how the landscape has changed since then.
Sure, absolutely. Well, first again, I'm gonna review my background's in emergency medicine, and how I got here was just seeing all the disease in the emergency department. As you know, all the preventable disease that we see day in and day out, and emergency physicians get and emergency departments get pressed for gunshot wounds and overdoses and multiple traumas. But you know this, Tro, what we see day in and day out all day long is the complications of vascular disease, the peripheral vascular disease, the heart attacks, the strokes, the kidney failure. And so that's what kind of spurred me in this direction a number of years ago. And I don't think I've told you this story, but I remember specifically one patient. I was working at the VA. I still pick up shifts in the emergency department at the VA in Dayton. And I was working one day, and you've got electronic medical records, so you can see the patient's problem list before you go see the patient. So I had a patient there with abdominal pain, like a guy in his mid 40s or so. And the abdominal pain ended up being no big deal. But I looked at his record and, he was diabetic, had A1C of 12.1. So, that's got to factor into your evaluation of the patient. So I went to see the patient and, we're reviewing things. And I said, and I see you're diabetic. And he goes, I remember it to this day, Trump. His words were, I used to be. What are you talking about? I used to be diabetic. He goes, well, I've read about, low carb and keto and intermittent fasting, and I've empowered myself to go ahead and change the course of that illness. So I went back and dug in his chart more, and sure enough, he had dropped his A1C from that high level to like 5.1. And as is often the case in medicine, this is we learn more from our patients sometimes more than we ever give them. And this guy really kind of changed the direction of my career, because I started doing some research, started following you, and it was evident that people can be empowered to reverse the course of their disease. So that was a significant event. And then, I went and opened my metabolic practice, started as just a little, as little practice here. in the Dayton, Ohio area, and we've been growing over the course of the last 4 or 5 years. Telemedicine component, working with a PA and an NP, and it's just exciting how we're kind of, stamping out metabolic disease and insulin resistance one patient at a time here in the Midwest.
I mean, it's needed. You look at the world now, over 90% have some component of metabolic disease, and it's a travesty. It's really, I don't think people understand. I think we've accepted this slow creep of disease in our lives. So, can you talk a little bit about, we're talking about metabolic health, and maybe we could talk about the FDA approval of, CGMs for everybody. And maybe you could talk a little bit I mean, I think it was quite, I mean, you called it. You wrote a book title with it, So talk maybe about the landscape and how it's changing, and maybe we could talk about the book a little bit.
Sure, thanks. You alluded to this. Continuous glucose monitors are going over the counter this summer for the first time. So people will not have to go to a doctor and get a prescription. They'll be able to get a CGM over the counter. And of course, CGMs will provide those individuals 24/7 readings of their glucose. And they've been used for years for patients to help dose insulin, but they're invaluable tools, as you know, in your practice, Tro, in terms of enlightening people. You can have people that are overweight, have insulin resistance. Their doctor would have been talking to them for years about, oh, what's the term, eat less and move more. The light bulb doesn't go off, but you put a continuous glucose monitor, and you've seen this, I'm sure, with multiple patients, on the back of somebody's arm, and they see the graphs on their phone, giving them the 24/7 reading, seeing the peaks, at times, seeing persistently high levels. And it's the last chapter in the book is CGMs change lives. And I'm going to stand by that because I have patients, and I'm sure you have too, that their healthcare future is redirected, in that first 2 weeks. I put them on, I tell people not to change their diet. Let's just go ahead and follow your numbers. And once they understand that, along with the fasting insulin level, they feel empowered to manage their health. And that's really where, in many patients in my practice, the reversal of metabolic disease starts.
Yeah, I think, it's a self-empowerment tool, really. That's I think the part of this that, can there be a little anxiety? Yes, seeing, data you weren't once aware of, that can, cause a little bit of anxiety. How do I interpret this? What do I know? But, today I don't hear anybody saying that thermometers cause anxiety, or blood pressure cuffs cause anxiety, or heart rate monitors on your watch cause anxiety. I mean, this idea that there's some systemic harm was completely bonkers. And it turns out that most of the people saying that, right, have strong feelings against low carb diets. Most of the academics who are propagating these messages, have strong feelings against low carb diets. And, I don't think I'm not a lover of the FDA, but in working with the submission to the FDA, they reviewed all the data, and there was no evidence of harm, besides the little rash that you get, using the CGM, or, maybe you hit a little blood vessel or a little nerve, but there's no real harm from these devices. So, I think it's a big deal. And I think the tsunami of metabolic health and diabetes is only going to get worse, because now people are going to be able to access that information even easier than they once were. So I think, people like you, me, Brian, there's going to be an onslaught of patients as these become more widely available.
Yeah, I mean, I view this as almost the democratization of health, of people being empowered to take care of their own health. Yeah, you can go and get a CGM, you can see where things are. So the process is going to be this is so, and I don't know if you know this, but the FDA approval for these over-the-counter CGMs is still advised. It's still advised for diabetics. I think the FDA approval includes, it's basically for diabetics who are not on insulin, and they have a disclaimer that it's not for hypoglycemic episodes. But if anybody can get one, which is great, then that means that it's not only diabetics can get their hands on these, pre-diabetics can get their hands on these. And heck, people with insulin resistance years before they're even pre-diabetic can get their hands on a CGM. And again, I think it can change the course of their lives. So this is coming sometime summer of 24. My understanding is they're going to be available at drugstores initially. Eventually I'm sure you can get one on Amazon as well. So I think it's really going to be a great thing. And yeah, I think when people have more knowledge related to what's going on with their metabolic health, that's going to hopefully allow us to help more people as well.
Yeah, I think, it's going to be interesting because you'd imagine, let's just like play some 4D chess. The next thing that happens is, the widespread, self-education on diabetes, right? Or more widespread. So more people are going to learn what foods are sort of, exacerbating their diabetes, and hopefully people will learn what foods are not exacerbating their diabetes. And so there's going to be a huge shift to low carb diets, I'd imagine,
I would
right? And
too.
when that happens, they're going to lower their A1C number, right, on their own, and then they're going to go to their doctor and they're going to say, "Do I have diabetes? Do I still have diabetes?" Right? And I think, we're going to start to have this discussion play out in the sort of clinical landscape. Well, what does it mean to be, you know, like reversed? Or what does it mean to be diabetes in remission?
Yeah.
So, I mean, let's segue into that topic a little bit. How do you feel about the term reversed?
Yeah, so obviously, I think diabetes. This is just my personal perspective, and I got to tell you, I'm conservative. I'd rather under promise and over deliver for patients than I would the converse. So I have a tendency to be a little bit conservative. Can people have their diabetes put in remission? Yes, I mentioned the one patient, that really kind of changed the course of my professional career. Will he avoid ever progressing again to diabetes? I hope so. I think he has the power to do that long term. Is that going to be the case with all diabetics? No, it's not, because as you know, you can't reverse disease in all diabetics. People that have been long-term insulin dependent, people that's pancreas is kicking out much less insulin or no insulin anymore, it's going to be very hard for them to reverse that process. But I think the majority of people that are early in their disease process, recently diagnosed diabetics, they can certainly put it in remission. I have a tendency again to be conservative. This is kind of my emergency medicine background. It's like if I send two chest pains out the door over a 30-year career and two people die, that's a bad record. So I have a tendency just to default to the more conservative position. Pre-diabetes, I think there's no question you haven't crossed that threshold. 100% reversible. I prefer, and you're probably got more expertise in this area than me, but I prefer to use the term diabetes in remission.
Yeah, I think the problem with diabetes is actually, and maybe we could talk about this, it's not one thing, right? Type 2 diabetes is not one thing. It's actually
Yeah.
like three or four things, right? It's the beta cells making a hormone called insulin, right? That's one component of it. It's the well, and then let's just add on endogenous GLP and glucagon there, right? And cortisol, some other hormones, but predominantly insulin, right? And then you have, insulin resistance. So how well all the receptors in your body respond to that hormone. And then on top of all that, you have the amount of dietary carbohydrates you bring into that system, right? So it's like three main things, right? Three main things, and certainly some other smaller stuff. So, when we're talking about reversal, like, can you reverse diabetes that's caused by 20 years of alcoholism that's damaged the pancreas? You have a calcified pancreas, right? Can you reverse that? No, you're not going to like decalcify the pancreas and bring it back to life, but you can, by going low carb, you can make that, the demands on your body less. Like it doesn't need to make that much, it can't make that much insulin and doesn't need to, right? So what do you think? I think the problem in the academic space, this idea of reversal or remission, is really because we have trouble really communicating, even internally amongst us clinicians, what diabetes is. What do you think?
Yeah. Yeah, well,
Is that too complicated for this for the
no, well,
podcast?
you just pointed it
Yeah.
out. It's multifactorial. And I'll be honest with you, with my patients, I try and simplify based on what I can do for them. If I have people that come in and, they've been on 120 units of insulin for, many, many years, I mean, I'm honest with them. It's going to be difficult, if you go ahead and, know that they are not making adequate insulin. It's going to be difficult to completely reverse that. So I think it depends upon really what they're bringing to the table individually. But obviously, improvement uh, is a everybody is able to improve their numbers, decrease their medication use, or eliminate their medication use. I think you and I were talking a little bit before. It's just really a matter of semantics here to a great degree, because from a pragmatic level, from the guidance we provide our patients and the support we provide them, I don't think it matters that much. So I got to share something with you though. I know that most people listen to this as an audio, but so I work at the VA. There's a in the emergency department still, there's a journal that comes out to all the VA practitioners. And you can see this. I know your readers can't see it, but it's the cover was, "Does keto hold promise for type 2 diabetes?" And this came out like in the last month or so. So I had to put this question to you, Tro. I mean, what do you think? I mean, it did 100 years ago before there was insulin. So I don't know. Does it hold promise now?
Yeah, I'm even scared to see what that article says inside. It probably is quite interesting. But like it's funny. It's a very we live in a very propagandized field. Like sometimes we take it for granted, right? The last like 5 decades of medical education have been largely around defining illnesses, right? And then diagnosing those illnesses and treating those illnesses with medications,
Right.
right? And so when you step out of that paradigm, it's like it's such a funny and silly title. Like, yes, bringing in less carbohydrates into a system that doesn't process carbohydrates has potential. Yes. Like it's just such a funny like world we live in, and the stuff we argue about as docs, it can be a little bit silly. And what makes it worse is you go to WebMD and they're saying the same thing, like keto is
Yeah.
going to cause you a heart attack. I mean, it's tiresome, you
But
know.
what has pushed that agenda? I mean, you thinking about, and we were talking a little bit before as well. It's really the entire system is set up for disease management, just like you mentioned. And, when I was getting out of residency, there were still a lot of docs that were hanging out their own shingle, joining small groups. I think the numbers now are 80% of docs either work for health systems or, private equity or publicly traded groups. The approach I think is very regimented now. And, Tro, you were in that system.
Yeah,
The
so are
primary.
you, right? Maybe you could talk a
Yeah.
little bit about that.
Well,
Um,
I bucked a little bit of that. We'll talk about that in a second here. But but the docs are now regimented now. It's like, you get, some people say 20 minutes, some people will say, 7 to 10 minutes with the patient, and they don't like it. The majority of docs I talk to know that they aren't doing as good a service for their patients as they could do otherwise. It is, well, let's tweak your insulin, let's tweak your hypertensive, see you again in 6 months. And that's why I think, people are drawn to practices like ours where we can roll up our sleeves and get to the root of the problem. But the system is different. And so when we talk about, keto holding promise for type 2 diabetes, it hasn't for the last 40 years because the system, whether that's, and I'm not going to be a conspiracy theorist and bash everybody, but it's because of the health system now and the way docs are relegated to be providing medical care. It's obviously the food processors, and the way to make cheap food that isn't helpful. And then it's the pharmaceutical industry as well. And it's happening again now with GLP-1s.
Yeah, I think, when you come back, I always like to look internally, right? So, yeah, are there, big processed food companies paying the American Heart Association and the American Diabetes Association? Yes. Is there government and sort of regulatory capture, right, at play with industry and governmental policies? 100%. Nobody disagrees with anything I've said so far, right? Um, so, but ultimately, right, I gotta, like, if we're gonna blame somebody, right, it's look at us, right? Are we going to be lemmings as a profession? Are 80% of us going to be, you know, are we going to be handing out prescriptions because it's easy? Are we going to be billing people for facility fees because it's more lucrative? Are we going to be bringing people back just to bill another occurrence? Right? So I really blame physicians and it's hard. I get it. You get out of school, you got a huge, student loan to pay, and you want to get a good paycheck, and it's scary and it's frightening, and your only options are a hedge fund, a private equity owned, emergency. Look at what happened
Yeah.
with emergency medicine. We should talk about
Yeah.
that because people don't know. Um, or it's a big hospital system, or it's a big, a hedge fund owned, group, or it's CVS that wants you to see them as quick as possible and write a prescription because that's how they generate revenue, right? They have the PBM. So it's I think for 8 years, when you've drilled your head down and learned, and you get to this point where, and now you're in debt, right? And all you've done is do what you're told for maybe even 12 years, right? You had, you know, 4 years of college, 4 years of med school, 4 years of residency, 12 years you've been doing what you're told. And now that person has to think for themselves, think independently, think in a way that serves their patients and not in a buck the system if it's not in line with their patient's wishes. I mean, it's exactly the worst person to actually pick up the mantle. So what do you
Yeah.
think about that? I mean, I
Well,
I blame us.
yeah. Well, you went through that transition and you know how hard it is. I mean, you probably more than anybody. And that's tough. I mean, I'm sure you recognize retrospectively how tough that was. But I think some uh newly minted physicians will have the opportunity to do that and will take that opportunity, but I don't think everybody will. So there are nationally prominent people that are part of the metabolic health movement that are, because they work for health systems, that are still muzzled in terms of, what they can say and not say on a podcast or whatever. So it's tough out there. I think the answer is for patients to empower themselves, they need to seek out a physician that's willing to buck the system a little bit and pursue that. So I think It's not going to be all docs. We aren't going to change all of medicine, I don't believe. But I think there are selected physicians like you and me, hopefully, and Brian and a
Right.
number of others out there that people now are having the opportunity to choose, a physician that can help them as opposed to just somebody that's going to be managing their disease. So,
I want to, I don't think we've ever gone through how medicine has devolved,
yeah,
and I'm wondering, if you can, you've seen, and I think there's no better example than emergency medicine,
yeah,
right? And, people, when you and I talk about medicine changing and us trying to change medicine back,
yeah,
the listener, I don't think they have a great understanding of what it felt like to be a doc. I don't even know what it felt like to be a doc 3 decades ago. I don't know what it was like 2 decades ago. I certainly know, well, 2 decades ago, I know. 1 decade ago, I know very well, and I know what's happened over the last 10 years. I'm curious to hear just your observations of how, because eventually you broke out, right? So
well,
can
yeah.
you walk like, can you help the listener understand what has happened over the last 3 decades?
Yeah, but I'm going to say to some degree, back in the 80s, I think it is some relevance to the way you run your practice now. As an independent, I mean, you're an independent business owner with the patients. I guess we're supposed to, I like to call them patients. I've been told we should call them consumers and clients during those eras. But it's what you're doing now. Making your patients the priority, and that's the way it was. Back in the day. But my personal journey was that, I got out of my residency and we started a small emergency medicine group. And the way this works for people that aren't aware of it is that groups of physicians contract with hospitals to provide the physician staffing of those emergency departments. And we had a lot of fun and a great ride in terms of, starting with a couple contracts and over a period of time, because I think of a good quality service and of being able to attract physicians who like that model, we built that to 60 contracts, a pretty, sizable group. And then private equity took notice of what we were doing. And that happened a lot in that era with
And that was the early 2000s, right? Right, like
yeah,
when private equity really, and
yeah,
hospital systems also, right? So it's the same time they were
same thing.
both reaching in the same bucket. The hospital systems are saying, maybe we can get a piece of this, and then the private equity is like, maybe we can get a piece of this.
Yeah, yeah. And so the same thing and that affected the emergency medicine contract business because you would have hospitals that were being swallowed up by larger health systems. I don't know if you had this recollection, but way back in the 80s, what happened was there were, 8, 10 health insurance providers in each market. And they consolidated. Now I don't know what it is like where you are, but now there are two or three in a
Two or
market.
three.
It's an oligopoly. And so what happened was the hospitals responded. Hospitals were closing during that era in the early 90s. And so they responded by consolidating as well. But like in my area now, the Dayton, Ohio area, there used to be 8 or 10 independent hospitals. Now there's only 2 health systems. So that was the response. And then the docs,
And then they
were
started buying up docs, right? After the
well, yeah, that's
consolidation, right?
yeah, the docs, there were some selected doc groups that were able to grow and consolidate, but mostly during that era, docs ended up selling their practices to hospitals and became, basically became employees. And most docs now, as we've talked about, were basically employees. So in my journey, we grew the practice. There quite honestly was a little dissension in the practice about what to do next because private equity was calling, and they were putting big numbers on the table in terms of selling the practice. And I actually exited the practice before that. I didn't like the model. I exited the practice before that occurred, but eventually the practice was sold to a public entity that basically was a Wall Street firm. And then that industry has struggled in recent years, and they've kind of bounced. The large emergency medicine groups have kind of bounced back and forth between being public entities or owned by private equity. Um,
So,
but
so let me give a flavor to the listener of what that means. So basically, it was, there was a combination of these small hospital groups, hospital-run administrative groups versus small private sort of doctors helping the hospitals get staffed and do what they needed to do. And as they became more established and grew, as sort of physician-run organizations, they just got bought out by hospitals. They got bought out by hedge funds and private equity firms. And it used to be that emergency medicine was one of the most sought after fields in medicine. Like if you were a medical student and you were, applying to residency, emergency medicine was really sought after. And this is really before 2005
yeah,
and up to 2010. And as this consolidation occurred, they started short staffing as they're bought up by public entities that are, more profit driven. The quality of the care went down, the quality of the positions went down, and now like where every single emergency medicine spot would be filled,
yeah.
any education spot that would be filled. Now there are programs all across the United States that are looking to get residents and they can't even fill the spots anymore. It's like the
Well,
least desirable firm, all because private equity has ruined the
it, it's
ruined.
yeah, it's an amazing transition. I mean, the service that we have been provided to a great degree has been commoditized. It's just and I worry long term. It's like for some groups, it's like we just have to get a physician in the emergency department in rural Ohio, let's say. It's a second thought as to what's the quality of that doc or the level of service they were going to provide. I got to say that is not true of all groups. My wife's an emergency doc, and she works for one of the larger groups, and they've been able to maintain some equity ownership amongst the physicians there, and I think they do a great job. But the model has been, and you put your finger on this, the model has been cutting staffing, in terms of the patients per hour that you have to see. And it's just tough, and people don't want to do that. And then, of course, you got the night shift and the weekend thing to go along with that as well, which makes for a little bit of a tough lifestyle. So people are choosing other paths, and the emergency medicine residencies are not filling.
And
It portends.
the same thing with internal medicine, and same thing with primary care, right? It's largely been bought up, and now, as you mentioned, 80% of primary care doctors are employed. They are not independent. They are told what to do. I mean, it is astounding. You
Yeah,
know,
yeah.
what do you think that means for our profession?
I think it's a tough landscape long term. I think docs need to think independently and take some risk. You got to take a leap of faith like you did, Tro, to some degree. I did starting my metabolic health practice, like Brian has. What I mean, because the system, I don't want to sound negative about this, but it's going to be difficult to change from inside. If you're, John Smith, MD, working in a large health system as a primary care doc, being asked to see 35 patients a day, it's going to be hard to change that. And the only way to do that is to step outside. And unfortunately, docs have not been great. This is pertinent to some discussions we have. Docs have not been great about consolidating themselves, about changing their small groups into larger groups to survive. We all have a little bit of an independent streak in us. And that can happen, and it does happen, but it's a little bit difficult.
We need docs like you. I told you, 3 years ago when we first talked, I said we We need docs like you, especially in the metabolic health space. If you've questioned the food pyramid, if you've questioned the CDC's recommendation that all diabetics should have 50% of their calories from carbohydrates, if you've questioned any of that, right, it means you think differently, right? It means you think differently. Whereas, 80% of docs don't think differently. And you see that sort of as, pandemics unfold, right? They've been programmed, through their education to just buckle down and this is the curriculum you have to study now. This is what you have to do now. This is what you have to do now. And they don't sort of ever get to break out of that. So now when you take metabolic health docs, well, they're all vehemently independent, right? They're all, they're willing to think differently. So how do you bring those people together? I'm curious, because you have I forgot to mention this, and so Jack, add this to his list of achievements. He's also a master's in, he got a master's in an MBA, right? So you have a brilliant business mind. You've sat as a physician sort of executive. How do you see, the metabolic health docs of the future working out in a landscape where, it's moving to AI and machine learning and how do you see if you were a doc that was just coming out of residency right now, what would your advice be?
Well, I think I think the foundation of this, and this may be a little bit old fashioned, but I really think ownership is the key. Okay, if docs are going to consolidate, they have to have some equity in whatever entity they're consolidating into. Because this harkens back to the primary care doc in rural communities where they're really just small businessmen. And they would put their patients as a priority. But they basically own the practice. And I don't know what your perspective is, but mine is that if you have ownership, you care a lot more. You care a lot about all the what's going on in the practice, what kind of care is being provided to your patients. You care a lot more. So I think equity, even if it's a sliver of equity as part of a larger entity, is huge. And then, of course, since COVID, the ability to consolidate practices because of telemedicine and the technology, I mean, your practice, I think, is probably the best example of leveraging technology to provide a higher quality service for your patients. So you integrate ownership along with the application of technology and allow docs from different geographic areas to go ahead and consolidate and provide a higher level of service. And that's the only way you potentially, I think, can counter those larger entities that are at sometimes opposition to us, which are the insurance companies and the health systems.
Yeah, it just seems, over the last 5 years, how has your practice changed? I mean, we briefly mentioned these new drugs but there's been a lot of sort of advancement in metabolic health and an understanding of lipids and understanding of blood sugar fluctuations. And, now I think on every day I see a new headline talking about Ozempic, Mounjaro, Zepbound, and, Wegovy. How has the metabolic space changed in the past couple of years, in your opinion? And how are you handling that?
Yeah, I think the big application is technology, remote monitoring, whether that be blood pressure or weight or ketones, so that we have a good understanding of what's going on with patients. We can intervene. But you know how it is, Tro. It's like most patients, they know you're looking at their data, they're going to self-correct. Most of the time they don't, they know that, we're watching and we're going to be talking about their numbers with them at the next visit. So they self-correct. And, to talk about another aspect of technology, which is the pharmaceutical development of the new, GLP-1s, is important. My perspective on that, if we can go there, is the genie is out of the bottle on this. And unfortunately, people are, sometimes maniacally focused on just getting a shot. And as you and I talked briefly, I use these medications in my practice, but I use them in limited doses and I use them in a finite framework. We're deep prescribers, as you mentioned. We are not people to come in and just add additional medications. But the way I look at this is that people are going to seek these medications, and rather than going to the internet and having a 10-minute visit and getting sent medicine for the next 6 months, I think a metabolic health practice like ours is a better option. So the way I use these is I will use them initially out of the gate with the patient. If I know I'm going to lose them to somebody else, it's just going to do it anyway. But we have the discussion. We're going to use limited doses and we're going to use this for a finite period of time. And then the other time I use them is it is for patients that stall and get frustrated. I try and work with them and have them keep the course. But occasionally, again, we'll use limited doses for a finite period of time. It's the old Stephen Covey adage out of the Seven Habits book, which is begin with the end in mind. And the end in mind is not to be medication dependent for the rest of your life. The end in mind is to look at a limited period of time where you've got the habits in place to counter the muscle loss that occurs on these medications and the weight regain that occurs when you go off the medications.
Yeah, I mean, I can't agree. I can't agree more. It's a very challenging time when docs hand this out like candy. I think, you hit all the important points. If you're going to be on this drug, you have to use it for as little as possible. The longer you use it, the more implications for the thyroid. And what does that medication replace? So if the medication is replacing, say insulin or, some blood pressure medications that you no longer need, well, maybe that's a great option, right? Maybe that's a great option. But if it's replacing the journey that you could have done, right, with a little bit of coaching and a little bit of perseverance, well, maybe that's not the best choice. So I think it's so really individual. We use the medication. We embrace Medicaid. We're medical doctors, right? Um, in the paper that we're working on right now, which will be published soon, I mean, we were neutral on its use in a big group of patients, in a group of 100 patients. We basically stopped the right people. They kept losing weight, and we started people who had severe disease and probably would benefit from the medication. And we were neutral on these drugs, and yet we got great outcomes. More than 40 pounds of weight loss at a year. So I think that's, it's a problem, right? Sometimes we have purists who say no drugs. Sometimes we have in the current system is like drugs like candy,
Yeah.
right? We have to, sort of figure out the balance. It
Yeah,
sounds
the
like that's
truth
exactly
is,
what you're trying to do. Yeah.
yeah, the truth is often somewhere in the middle. It's like as opposed to no use or excessive use. But the key for people need to know what they're getting into. And the key, like, yeah, I mean, to talk even numbers, I think Wegovy goes up to 2.4 milligrams or something like that. I seldom have patients on more than a milligram. And you titrate up slowly and then you titrate down slowly. So I think, I don't know if I want to call them a necessary evil because they have their place, but I think there's a lot of inappropriate use out there, and I don't think people know what they're getting into in terms of their long-term dependency. And then we all see people that get stuck even on the medications, and they what they want to know, I mean, we have those people, they come in, they want the medication, they don't want to do the other things. We talk about doing all the other things, and then they kind of fall off despite us staying on them, and they think the medicine, they lose 40 pounds, they think the medicine's going to help them lose another 20 or 25 pounds, and it just doesn't work that way, you know.
Yeah,
You
we've
got to be doing the other things.
100%. I mean, we've seen, we were early users of the medication in diabetes because, you know, in people who literally did diet, I mean, and exercise, like we have completely fat, but some people's beta cells don't function, right? This is the complexity of, they don't function the way that they should, and a little bit of GLP, is better than taking insulin. Um, it's and then we have other cases, I have people asking sometimes, I got to lose weight for a wedding, and it's like, okay, that's not what it's for.
Yeah.
But it's
It's
hard.
not bad to have a goal. Sometimes it's good for people to have a goal as long as the mechanisms to achieve that goal are applied properly.
Yeah, I'm 100%, I think, ultimately, it's that, having an open relationship, having that open discussion. But, navigating this will be different, and I think, it'll be judicious use. If the entire country who is suffering from obesity or who's overweight or who has diabetes or pre-diabetes, right? If the entire country goes on these medications, it'll bankrupt every company out there. It'll bankrupt every employer. It'll bankrupt governments. So we have to, and the worst part is not everybody can tolerate them. About 50% can actually tolerate these medications, the nausea and the vomiting or the GI side effects, and the long-term issues of the muscle loss, as you mentioned, and the thyroid issues, which increase with time. So some people will opt not to. So we need to come up with ways to really get people to, how do we transition them off these medications? There's data now showing that exercise helps prevent weight regain, which was seen in all the trials where the weight rapidly came back. Um, there's data, we have data showing that people can effectively do this if they have the support they can effectively come off these drugs if they have the support to remain on a low carb diet. So I think the name of the game will be how do we safely wean people who no longer need this? It's not the drug that's a miracle, it's the weight loss, right?
Right. Right.
So I wonder what you think about all this.
Yeah, I think again, you begin with the end in mind. I personally have had great success weaning people down, because they understand the program. They understand that they've had lifestyle changes while they're on the medicine. And so, weaning people down and off the medicine actually has not been a problem. There's probably going to be a whole industry for us, Tro, going forward of getting people off the medicine, all the people, that then have been prescribed this medicine without the good support of the lifestyle changes we talk about. And we're just really a couple years out now from the use of these medications. And now people are realizing, for whatever reason, that they're going to have to envision a world for themselves where they're off medication. Some employers that initially paid for the medication because it's breaking the bank are now not approving the medication within their insurance plans on their formularies. So again, I think it's critical, to have metabolic health support. And I'm seeing patients come to me that have already lost the weight and they just want to get off the medication now, and we're helping them do that.
Yeah, it's so critical. I mean, it's such a big, I think the honeymoon is over, the honeymoon's over, and I think it's all, like long term, these are going to be an issue because after about 1 to 2 years, the effects on sweet cravings go down. And so, if you use this tool to lose weight over the past 12 months, now is the time to start planning how you're going to come off, what you're going to do different, how you're going to protect yourself as come off this medication. If you have diabetes, I'm not sure, I think it may end up being a best in class medication. But if it's just for weight loss or your diabetes is resolved, I mean, that's the time where I'm like, now's the time to start at least planning.
Yeah,
Um,
and the drug companies are looking at all other kinds of indications, as you know, heart data on heart disease now, data on fatty liver disease. what I see, I'm interested in your thoughts on this one. I have a previous life also with actually a board certification in addiction medicine. And I am, seeing lots of patients that are on this medication, that alcohol use goes way down. Are you seeing that as well?
Yeah, I see both sides of it, right? Alcohol use may go down, and I've seen the other side where maybe there's a bit of depression because their coping mechanisms were taken away, right? And they know it's like it causes anhedonia and a bit, which is a fancy way of saying it's just a loss of
Right.
interest, right? I mean, they're
Yeah.
excited about the weight loss, but they're like, yeah, they're like just not, if I had to guess, these drugs play on the reward centers of the brain,
Yeah.
um, which is, long term, not something that I don't think we want to be playing around with too long.
Right.
I have seen the alcohol come down. I wonder, what the mechanism is, but I don't think I think it's subtle. I've seen the flip side where, somebody's lost so much appetite and food was their friend and food was their coping mechanism. Now they turn to alcohol. So I've also seen that.
Okay.
Um, but there are a lot of reports on alcohol cravings sort of going down. You know,
Yeah.
what do you think?
Well, I think there's something there. I actually have had a number of patients whose alcohol use decreased. There have not been good medications, as you know, for alcohol reduction. Now, Naltrexone is probably the best one. Um, and uh, there have been other medicines in the past, antabuse, which I think is not a good medicine to use for listeners. That's a medicine that if you take it every morning, it will guarantee that you get sick if you drink alcohol. So it's kind of a punitive approach, and can be dangerous. So I don't think that's a good medication. There is another medication that you got to take 3 times a day that has not, I think, been helpful. I think there's going to be a big push to look at semaglutide and tirzepatide for addiction disorders. And again, I don't know if that's a good thing or a bad thing, but due to the dearth of medications that are effective with addiction disorders, and not primarily opiates, but primarily alcohol, I think this is going to become more common as well. And, again, it's a double-edged sword. Right now, the only patient that really would apply to would be a patient who is overweight and has an alcohol issue. So we'll have to see how this evolves. But I think there's no question that Lilly and Novo Nordisk and the other companies are going to be doing studies related to alcohol use disorder.
I mean, I'd imagine every indication they can get, right? They would look for
Yeah.
an alcohol use disorder does not need, any cardiovascular outcomes. So every new indication extends their patent life, extends their, so
Yeah.
it's will likely be done. Look, I think these drugs are here to stay. People ask me, I think we will find out all the long-term issues in the
Yeah.
next 5 to 10 years. And we have an idea of some of those from Victoza, and we have an idea of some of those from, other medications. But you have to look at it. I think you have to look at the whole landscape. If you have diabetes, well, these drugs reliably cause less heart attacks than the placebo, right? So the amount of data, I mean, the amount of data we have for these drugs is more than what we have for dare I say the COVID shot, right? And we have multi-year data with cardiovascular mortality data. So when your doctor prescribes it, he has a lot to rely on. It doesn't mean it's impervious. It's not all cause mortality data over multiple years, but it's fairly strong data. So I think embracing the medications is probably right. Then we have to consider the side effects, all of which we just mentioned: the lean mass, the thyroid issues, the thyroid cancer, the GI issues, and what exactly are we going to do when those reward centers adapt, like they do with bariatric surgery and with all the medications you just mentioned for alcohol that seem to work up front and fail in the long term. So
Yeah.
it's an interesting time. It's definitely an interesting time, and we may go bankrupt in the meantime, I think.
Yeah, I mean, do the know what 60% of Americans are overweight times $1,000 a month. I don't know what that number is, but it's a lot.
Yeah, that's a multi-trillion dollar, proposition. But the flip side is medicine is, this, what's interesting, and I feel like I'm talking way too much, but let me just say this.
Oh, you're fine.
All of the beauty of this drug actually came from a sentiment against pharma, right? So when GlaxoSmithKline in 2008 was caught lying about Actos and Avandia, right? And it was causing more heart attacks and led to multi-billion dollar settlements, the FDA guidance to industry was changed to require cardiovascular outcome reduction for any metabolic drug approved.
Yeah.
So it came from people skeptical of pharma and demanded their governments up the bar against industry, led the way to drugs that are reasonably good,
Yeah.
right? That are reasonably good. And these
Interesting.
drugs are reasonably good drugs because they're after the era of that guidance change, which came from everybody being so upset with the fraud that pharma, sort of put on. So it's an interesting time to be a metabolic health doc, and I think we have to, change. I've had to change. I'm generally a deep prescription clinic, but like I said, we've had, we have patients that we put on these medications with great success.
Yeah,
So
the
it's
landscape is,
nuance.
yeah,
Yeah.
it's going to be interesting going forward because pills are coming too. Um, GLP-1 pills are coming. The landscape with Medicare patients is interesting. Not that I think these should be used in older people, but the Congress has prohibited Medicare from paying for obesity-related treatments. I think you're probably aware of that. And so that's why, again, the drug companies are going to be looking for every indication they can to get around that, unless Congress ends up looking at that. But I don't see how that happens in the current fiscal environment based on the costs. So it's interesting. But I don't know. Have you had? I've had patients come, not only with Medicare but other private insurers, and they're just, they feel that a lack of coverage is not fair. So I don't know how to answer that. It's like,
Yeah.
let's roll up our sleeves and do the other things that are necessary.
Yeah, I think it's now more than ever that message is the one that's needed. Is what else can we do? And we have these amazing tools at an amazing cost. Well, what are the cheap, effective ways of actually doing this? And it's not, pointing a finger and wagging it at your patients. It's what can we do together? It's working with them using these tools like CGMs to empower change.
Yeah.
Um, any other like shifts in your practice that you've seen over the past couple of years that you're excited about, or any other, major changes or anything new coming from Dr. Colo? Yeah.
No, I look forward to the wider availability of the CGMs. I think that's exciting. And so I look very forward to that. We're continuing to just leverage technology. And I would say, Tro, I'm probably a little bit more along the lines of Brian, and it is that I just, having a moderate sized practice and taking care of people and seeing how you change their lives just gives me great satisfaction. So we use technology, we're using the medications to a limited degree. And then I'm real excited about CGMs being available to everybody. And I'm going to plug the book again, if I may here. Okay.
Yeah.
So the book is The Continuous Monitor Revolution for Non-Diabetics. It's available on Amazon. It's the most popular book on CGM use on Amazon. And I think, fortunately, as people, learn that they can just go to the drugstore and get a CGM, they're going to naturally have questions about how to use it optimally. So I'm just excited about working with more patients that are using what I think can be, as we talked about, a life-changing tool.
Yeah, we'll
So,
definitely put the link to the show notes, and we'll absolutely put that. And thanks for coming back. I'm sorry for the brain fart. I forgot you were already here. I thought it was the Life's Best Medicine podcast. That shows you, you know, how overworked I am.
That's okay, Tro. I mean,
Yeah.
if I wasn't memorable, that could be for either a good.
No, no, are you kidding me? Come on, we've met so many times.
Yeah.
You're definitely, no, your insight, um, and we're gonna need your help, so we're gonna need your help. So we're gonna get to know each other a lot better, hopefully.
Yeah, we'll be talking, and I know you didn't want to necessarily focus on this in this podcast, but I did have a previous life also owning a wellness company that did corporate wellness programs, and it was like wellness 1.0 as opposed to wellness 5.0 that you're doing with the companies that you're working with, and I think that area of your practice that intrigues me because you can really reach a lot of people in that kind of format. So I congratulate you for the progress you've made in that regard. I'm interested in hearing more about that and us maybe talking about working together because I think it's great to have people into your private practice one patient at a time, but the way you can impact population health, with a small or moderate size employer like Verta is doing with the big employers, I think there's a really, needs to be an effective option for those smaller employers, 50, 100, 300 employers. And, I've seen your data, you're changing lives with that program and you're reaching a wider range of people. So I think that's really exciting.
Yeah, I mean, we got to get back to the roots of medicine, and we need to do that in a financial structure that aligns docs with patients, right? And docs with outcomes. And I think the next step is figuring out how to include docs to own a piece of the pie so that they all have a same vision of, it has to be value-based care. We have to be paid on the value we produce for our patients, right? And that is the most important. If a patient is not succeeding and we're not asking ourselves why, or at least working with them to figure out why, what are we doing, right? And too much of metabolic health is, well, it's the patient's fault. No, like, yes, nobody can control a patient. That's true. I can't, eat for them, but I can work with them. I can work with their strengths. I can work with their weaknesses. We can figure this out. And I think value-based care, it has to come back. If I went to a doc who didn't help me, I wouldn't go back,
Yeah.
right? And so, that's my passion. How do we do this on a corporate landscape, which is, a little
Right.
bit more challenging. So you and I will
Well,
talk about it.
yeah, I mean, you've gone into employers and you've shared, I'm sure, your deprescribing data and how the risk factors for that employee population is improved. And how that translates, for self-insured companies into, them saving money. And, my
Well, I
experience.
thought you want to hear something interesting, and I didn't know this because I thought like, every self-funded sort of, CEO is going to be like, how much money can you save me? And it has nothing to do with that. Every single one that I've talked to, they look at me, I want a happy workforce. I want a healthy workforce. I want a workforce that, is excited about their job, that knows that their company is after their best interest. I mean, like we came at this corporate medicine landscape with a financial mindset, because we knew the power of metabolic health. We knew we can get people healthy, not needing medications. And all we have heard from the CEOs is the exact opposite, right? We don't care about the money. We know you can, we know there's going to be money saved. We got it, which is, I got to be honest, that was a huge shift for me,
Yeah.
in my understanding of how to approach employers.
Well, you've
Um,
selected the right companies to work with, the people that really sincerely have the health and the well-being of their workers in mind. And but they do know in the back of their mind we're going to be saving money. But it's not only about medical costs, it's about, less sick days, and employees being more productive. So, I think you're working with an enlightened group of people. So it's up to us to go out and find those CEOs and CFOs.
Yeah, and we're finding that they're reaching out, which is amazing. And along the way, if we can, like the money savings and the deep prescription is the side effect of value-based care, right? About putting patients first, about human connection, about, it is a side effect. It is not it's and it's tough. How do you run a business with that mantra? That's the tough part. And maybe you can help me with that one day, you know. Yeah. Because you got the MBA and the fancy experience. So, I don't have any of that. I just have, whatever I have, my
Yeah,
faults.
you look like you're doing pretty well. I mean, you're basically, I mean, to be honest, you're kind of the spokesperson for metabolic health here in this country. And I think we all appreciate the leadership that you provide, and you're branching out in these different areas like employer-based healthcare. And so, I think we all have a role here. But with the changes that we can impact, we can change people's lives as well. So
God
I
willing,
appreciate,
from your
yeah, I
mouth to God's
appreciate your
ears.
leadership, and I'm happy to ride your coattails, Stro.
Yeah, no, no, no. Come help me. How about that? Well, anyway, guys, get Dr. K's book, Dr. Kolo's book. I'll put in the show notes will be the link to this book on Amazon, his practice's website. He's in Ohio, but I know he does some telemedicine too. Just look out for that, and thanks for coming back. Thanks for coming
Yeah,
back. I'm going to see you again. I know next January. I see you every January.
yeah,
So
at
probably I'll be
least.
seeing you next January. All right.
All
Have a
right.
good.
Thanks for
Thank
having
you.
me on.